Now, sorry, everyone has to agree to be recorded and then take themselves off of mute.
Camera back on.
Sorry about that. Teams turns everything off when you start recording, so everyone has the opportunity to give consent.
Okay, we're back. If it's easier for you to see it online, if it's easier for you to see, you're not going to get connected. Great, so everybody gives consent to be recorded?
Yes.
Yes.
All right, so we'll go ahead and do a member roll call. So we'll start here. Bonnie?
I am Bonnie Blumenthal. I'm a licensed marriage and family therapist. Lived here for 11 years and know the school system.
Hi, I'm Tammy Rust. I've lived here 8 years and I'm a life coach.
Brad Rasmussen, I'm in the District 4 supervisor for the county and currently the chair of the board of supervisors.
Janet Taylor, radio host, and Connacht, I senior support.
Melanie Lynn, I work here at the Circle of Native Minds, and I've lived in Lake County for 6 years. Oh, and I've also been employed for 5 years.
I'm Stacy Bethel, and I'm the chairperson of the Behavioral Health Advisory Board for the county.
Laura Carter-Runyon, executive director of Hilltop Recovery Services, and I have lived in this community for 29 years.
I am April Gambra. I am the clinical deputy director for behavioral health, both specialty mental health and substance use disorder services. I am a peer. I am also someone who is a consumer or has been a consumer of our services throughout the county, as well as my family and most of my friends. I have been in the county for about 30 years.
Oh, Carrie Manning, supervising behavioral health clinical specialist, primarily with the peer support centers and street outreach. And I've been in Lake County since 1995. So is that like 31 years now? Yeah. So, and all of my kids have been raised here, and it's a great community.
We're just doing introductions. We'd like to introduce yourself.
Bruno Samacci. I'm District 2 Supervisor for the County of Lake. Stop there. I won't give my life story.
That wasn't my life story, trust me.
Oh my goodness, pass the bump.
Hi.
So, anyone online might introduce themselves. Scott, would you like to?
Oh, I'm sorry, I didn't hear you there.
Oh, sorry.
Hello, my name is Scott Abbott. I'm work here at Lake County Behavioral Health Center as a program manager for the BHSA now and also housing. And we'd like to welcome you out. This is our, actually, as you probably be able to pick up, this is our Behavioral Health Advisory Board. It's actually their official meeting. It's where they're doing the roll. They did the roll call for themselves. But they are hosting our public hearing as per regulation. And I would like to turn it over to Elise Jones, our director, for a welcome.
I think we have more introductions. Are we doing online introductions as well?
I wasn't planning on that, but okay.
Hi, I can introduce myself. My name is Amber Westfall, and I'm a program manager with Lake County Behavioral Health Services. And I oversee all of our substance use disorder programs and services.
Hi, I'm Christine Andrus. I'm the Deputy Director over Administration here at Lake County Behavioral Health.
Galen Roberts, Clinical Director of Hilltop Recovery Services. I've lived in Lake County for about 30 years.
Good morning, everyone. I'm Alicia Adams. I'm a program manager here at Lake County Behavioral Health Services, and I manage some of our clinical teams. And I think I've been in Lake County 55 years now.
She wins.
Hi, I'm Megan Morgan. I'm the Community Liaison at Lake County Behavioral Health Services.
Good morning, everybody. My name is Michelle Lampkin. I work at Lake County Behavioral Health Services as the Operations Manager.
Hi, good morning. My name is Summer Walker. I'm a program manager, newly hired.
Jump in. Hi, I'm Susan Polyakonis. I do not work for the county, and I actually don't live in the county, but I have worked in Lake County with a number of different organizations and a number of people here since 2014, and I am one of the leads of the Charm Project.
I'm Rachel Nell, a housing coordinator for Lake County Behavioral Health.
I'm Melissa Kopp. I work for Lake County Behavioral Health Services as the Continuum of Care Analyst.
I'm Amanda Hicks. I work with Lake County Behavioral Health as a substance abuse counselor. I've been with the county for 3 years now and a counselor for 2. And I've been a resident of Lake County. Well, I was born here, but I've been back here for about 4 years.
Good morning. I'm Amber. I'm our fiscal manager here at Behavioral Health.
Hello, I'm Rebecca Vasquez. I'm a case manager and peer support specialist at Lake County Behavioral Health mental health diversion team, and I've been in Lake County since the year 2000.
Okay, I'm Jamie Reno. I'm with Lake County Behavioral Health Supervising Specialist, and I've been here in Lake County for 3 years.
Everybody?
Hello, I'm Courtney Chappell. I'm with RDA Consulting, and I'm here with my colleague Jamie Dorsey. We've been working with Lake through the integrated plan development, and we'll get to share a bit more later. So thank you.
And Jermaine Gregoire, Lake County Behavioral Health Services, Staff Service Analyst.
Timothy Lawback, case manager for the CalWorks CWS team at Lake County Behavioral Health Services. I lived in Lake County for going on 12 years now.
Hi, this is Ken Johnson with the Big Oak Peer Support Center, peer support specialist for Lake County Behavioral Health Services.
We're with the Harbor on Main Youth Resource Center. I have Stacy Johnson, myself, Raven Wilczewski, Kayla Calvillo, Jocelyn Chappelle, Jen McQuaid, Katrina Bryant, and Kim Guerra. Or McGuire.
Yes, she did.
All right, welcome everybody, and thank you for joining our meeting today for the public hearing for the BHSA Innovative Plan 26 and 2029. So, first up is agenda review and additions. Do we have any comment on the agenda from your report? We have a motion to approve the agenda.
I motion that we approve the agenda.
Do we have a second? A second. All in favor?
Aye.
All right, so next up, we have the BHSA Integrated Plan Overview and Presentation by LCBHS staff.
Good morning.
Hi, Elise.
Hi. I felt like it'd be better because we're in multiple centers. That I would be here, that I chose so I could broadcast to everybody. I don't know. But I am ready to go.
All right. Well, Elise, do you want us to start with the intro pieces, or is there anything else you wanted to say before we do the kind of the high level intro?
I would just say thank you everybody for coming and participating. It is so great to see everybody here, and we have a lot of ground to cover today. So let's jump into it. Oh, yes, I'm the director of Lake County Behavioral Health. I can't remember if that was said, but hello.
Thanks, Elise. Just a quick check. Is everyone able to see slides now from what I shared? Okay, great. Thank you. Well, again, my name is Courtney Chappell, and I'm here with RDA Consulting. We've partnered with Lake over the last year and a little bit before that to really work through the BHSA integrated plan development for this fiscal year 26 to 29. And here today, we're really here to present the integrated plan, the draft that has been out for review. This is closing that public comment period. This draft was submitted to DHCS on March 31st. And I know many of you are here to hear about what are the current plans and anticipated programming for Lake County. And so we will make sure we save much of our presentation time for Elise and Scott and team to share those updates. But we also want to just remind and reshare all of the kind of background that brought us here. So we're going to give a very brief overview of BHSA. We'll review some of the development process, which will include the community planning process that many of you participated in and came to community planning meetings. We'll then kind of set the next piece by a brief overview of what are the differences between MHSA and BHSA, those plan requirements. And then Lake will be able to walk through and highlight what are some of those programmatic and funding changes, and what does this look like, and like what are the impacts that you all need to know about. And then following our time, I know the advisory board, please ask questions throughout. I think that's okay. But I know you have a time then to discuss and ask more questions after with public comment. So thank you for that. And then my colleague Jamie is on. Jamie, if there's anything in the chat I miss, can you just let me know? I can't see all of the different screens when I share. Okay, so we're going to start with a brief overview. What is the Behavioral Health Services Act? So this is probably starting to become familiar from past meetings, but what this was Proposition 1 is an initiative that was proposed by the governor and to modify the behavioral health system. It was really emphasizing the expansion of housing and treatment options for those with serious mental illness. This did pass in March of 2024. And it really is looking at a few key priorities. So focusing on the most vulnerable individuals living with serious mental illness or substance use disorders, and that are at risk of homelessness, being unhoused, or perhaps justice involved. It's about increasing access to permanent supportive housing and residential treatment, increasing access to substance use disorder treatment and co-occurring services, and creating transparency in behavioral health planning, including things like fiscal expenditures, outcomes for those receiving services. And we are coming up on full implementation. So that is expected here in July. So July 1st, 2026, where this plan is focused. So just kind of a note there were two components to Proposition 1. So the first component was the Behavioral Health Infrastructure Bond Act that authorized about $6 billion to build or develop behavioral health housing and treatment. And then the other part was the Behavioral Health Services Act, which amends what was MHSA, or the Mental Health Services Act. So again, some of those key changes when we're thinking about moving from Mental Health Services Act, MHSA, to the Behavioral Health Services Act is looking to expand funded services to now include substance use treatment, so that whole behavioral health spectrum. It does revise the distribution of funding to prioritize housing in the funding complement, emphasizes full service partnerships and evidence-based practices as part of programming. There is a shift in prevention funding to the state level, and we're going to show you slides later on that show how this funding shifts, and then you're going to get to see the specific for Lake. It mandates an integrated plan for department-wide behavioral health services. So we're going to keep talking about that. It establishes behavioral health goals that inform planning. So those are statewide behavioral health goals. And then it really revised and required greater collaboration with a broader group of partners. So expanding on who should be a part of that conversation. And so the three categories that are really of focus when we're thinking about BHSA, what are those funding categories? And these are a little different from the MHSA categories, which we'll also get to see later. There were 5 under MHSA. But under BHSA, we now have full service partnership. So these are services that include comprehensive and intensive care for people at any age with the most complex needs. The second category is behavioral health services and supports. So this includes early intervention, outreach and engagement, workforce, education and training. It could be capital facilities and tech needs that the department or partners that need. It also encompasses innovative pilots and projects. And we'll show you again, I think, a graph and a slide that'll help show that transition. And the third category is housing. So this is a new funding category. It includes behavioral health housing interventions that increase access to permanent supportive housing for people who meet BHSA eligibility. And again, we shifted from 5. So before we'll look at that a little bit more. So that's really what brought us here. That is the background of what is BHSA, high level, I know. I'm going to show you a few areas you can learn more about that as we go through. But I really want to talk now about the development process. You know, what really informed LCBHS's Lake County's planning and resource allocation for fiscal years 26-29, what all went into the community planning process, and how that really engaged a wide range of stakeholders. Okay, so before we get into these specific pieces, want to just take a quick minute to review the totality of work that has brought us here. And that's really what this timeline is showing. Today, we're focusing on that final piece, the IP draft itself, but there were many pieces of readiness, needs assessment, plan development, community meetings that went into the aspects of this final draft. So what did that look like? There were 3 community meetings. There was a lot of participation across those meetings. In addition, there was a community survey. And beyond that, 9 focus groups were conducted, as well as interviews with a range of partners. Both participants were internal and contracted partners, managed care plan representatives, and many others. So there you can see one note. I know some of this is probably small depending on the slide view you're looking at. around 330 participants. That's not unique. Sometimes people came to meetings 1, 2, and 3, but this is who engaged and came to those community planning efforts. Additionally, we collected demographic data from those who participated in the community meetings and the survey. We did not for interviews and focus groups. And so this next slide I'm going to show you, you're going to be able to see where most of those participants, we had many participants from behavioral health providers or staff. Then we had participation by loved ones or individuals who were receiving services from Lake County. And then many other community partners such as housing service providers, medical health care service providers. And so that's this graph here, kind of showing you the distribution of all of the folks who participated, the type of lens they were bringing. Again, this isn't a one-to-one match. Sometimes people identified with more than one of these groups, and they could tell us that, you know, we're representing both a person who has received services and now a community partner or now a provider. So you have a little bit of that overlap happening. Okay, so from doing all of these aspects, the first couple of community meetings, the focus groups, the interviews, went through a process to really distill down the needs assessments. And there are more aspects of this, and I'm going to have a link here after about 4 more slides where you can learn more, or maybe you've already looked at the full community planning process write-up. But I wanted to share the highlights. What came out of this? What was learned from all of that communication? And so first, looking at behavioral health system strengths, some of those strengths that really came forward where the peer support centers offering accessible, welcoming, non-clinical mental health support. So there was a lot of appreciation for the resources, the encouraging of service engagement, being able to aid recovery in those spaces. Another strength noted was the enrollment process for behavioral health services is fast and easy for clients. The next was within the Lake County system and the broader behavioral health system, services for children and youth, such as like counseling, case management, were considered effective. Those services were doing well at teaching things like coping skills, boosting parental confidence and well-being, aiding in family system navigation, and reducing institutionalization. Another strength was Lake County's provision of a variety of services for substance use, so addressing needs as tobacco use, youth substance use, and opioid use. And finally, the behavioral health system partnerships have grown and improved in recent years. So increasing referrals across the community was another noted strength. So specifically things that were called out were things like the mobile crisis, the peer support centers, and kind of that effective piece of connecting clients to services and being able to leverage those partnerships. We also identified some gaps and kind of persistent needs over time. And so some of those that really stood out were inconsistent or differing referral practices. So while there had been improvement, this still felt like an area of challenge for folks. Sometimes, you know, privacy and data sharing restrictions are a part of that challenge, and those pieces were called out in this gap. And some of the participants in those receiving services really highlighted the need for more consistent follow-up after a referral is made. And so kind of ensuring that that connection actually happens, right? And so that's one area. Another was limited shelter and interim housing capacity. So heard from community members expressing the need for more shelter beds generally, and being able to meet a variety of needs. So like things like family shelters, shelters for individuals living with SMI or SUD, so severe mental illness or substance use, as well as things like shelters who can accommodate animal companions. So thinking about all of those unique needs of individuals. Another gap and need that was identified was workforce shortages and high caseloads across staff. So there was a lot, this is kind of a twofold, there was a lot of expressed appreciation for the dedicated and knowledgeable staff that folks are interacting with, and this acknowledgement that they're working with very high numbers of individuals, high caseloads, and some folks expressed a need for more intensive case management and navigation support, especially around obtaining housing and employment. Another area was also maybe a limit of services for those who have co-occurring, so both severe mental illness and a substance use. Really looking at ways to identify that overlap and where there is unification in those services available. Another was lack of in-network providers for private insurance. So we heard that from different areas. I should also address the caveat is many of the things that we heard maybe are not unique to something that the Lake County system can address in totality, but it's really good to know where are the challenges, right, that communities facing as they're moving through the needs they have. And then a final one was limited reliability and affordable transportation. So kind of this acknowledgement that there have been some creative solutions to support limited public transportation, things like mileage reimbursement programs, mobile service programs, have been really helpful. However, there is still a gap. There's limited bus schedules and coverage. It can be a barrier to engaging in services and making it to appointments at certain times. So again, really looked at opportunities then based on strengths and needs, what was coming forward to address systems needs and challenges. And so some of those at a high level were improving, improving referral and care coordination processes, expanding housing and homelessness support, improve accessibility and expand mobile services, expand access to peer support specialist certification and workforce development services, and expand provider service awareness and community engagement. And then finally, kind of a more overarching is prioritizing equity, inclusion, and cultural responsiveness. All right, and then just a final thing we wanted to highlight that really came through in that needs assessment and community planning process was, you know, who are the populations in need in Lake County? And those on the slide were those highlighted. So older adults, individuals experiencing homelessness, children and youth who are placed in the foster care, LGBTQ plus community members, those who are justice involved and reentry, as well as Indigenous, Hispanic, and other communities of color in Lake County. Okay, so that was really covering the highlights, the high level takeaways from that community program planning process and the needs assessment. I did just want to note that you can actually review that process more in detail or those findings on Lake County's Behavioral Health Services Act website. I'm not sure we said this at the top of the meeting too, so I apologize for that. The slides that we are sharing with you today are also available on the Behavioral Health Services Act website. So if there was something you wanted to look back at, I know there were some quotes on those slides from participants of focus groups or interviews. They are available to you, and hope you'll be able to take a look at those. Okay, so before we get to the specifics of the Lake County plan, want to just one more time look at the changes from MHSA to BHSA. The integrated plan looks quite different from the past 3-year plans, as well as the annual updates that we're used to doing, that you are used to seeing. And so just wanted to highlight some of those updates that might help with the updates that come later. So when we look at the MHSA plan to the BHSA integrated plan overall, what this slide is showing is some of the priority, objective, kind of rule changes, if you will, that have happened. So under BHSA, all counties must develop and submit an integrated plan. It has a similar purpose to the previous MHSA 3-year plan of planning for county services and resources, but there are also many differences. So first, when you think about the reporting focus, under MHSA, the planned activities and MHSA spending that was in the plan was really unique to that funding. Now, the BHSA integrated plan is really looking at a spending plan for the entire county behavioral health department programs and services. So looking at behavioral health, substance use, and housing, as we've noted. There are new data reporting requirements at the county and program levels. And it doesn't include program expense, service, and outcome reporting in the same way as you've seen in the past. That's going to look different in a new report that's going to be separate starting in later years, called the Behavioral Health Outcomes Accountability and Transparency Report. So that'll be a future sharing from Lake County. Additionally, the community program planning process, that has always been required for the 3-year planning and the annual updates. Moving forward, that will be required for the 3-year integrated plan. So the plan that you are all talking about today. And then it'll be encouraged for the annual updates. So a little bit of an acknowledgement, these happen quite quickly. And it really needs to happen for the 3-year planning with that encouragement for the annual updates. And with that, though, there is an expanded list of all of the different partners. Now that the plan covers more areas, more partners have been asked to be engaged. The format has certainly changed. Before, it was more of kind of a traditional narrative report. Now the county is required to submit their plan in an online portal. And the format is kind of a mix of text boxes, select buttons, multiple drop downs. It looks very different than it has in the past. And then the final changes, the due date hasn't changed, but now there is a draft due date where the counties have to submit their draft plans to the state for review. And that is March 31st, where that was not a requirement in the past. So some final things here, when we think about what's in the plan, right? What are the components that are really being focused on? Here we can kind of see the MHSA 3-year plan components and the BHSA components side by side. And you can see that BHSA side is an expanded list. There are some similarities, but the information collected is now more standardized across counties, so a little bit more state dictated. There are also many more sections than what we used to see in the MHSA plan. Some of those specific new sections also require things like exemption and transfer requests. So depending on how you're using your budget, that has to be approved by the state. Reporting on these new statewide provided and statewide behavioral health goals, as well as any county behavioral health service goals and the whole continuum for the county. As well as the county workforce strategy. So kind of what does that look like to build, retain, and develop workforce? Okay. So we've talked about some of these things where we kept saying, I'm going to show you a slide that helps show some of these changes. There'll be a few more ways to look at this that I know Scott and Elise will also help move us through, but here's kind of a starting at a high level of when we look at MHSA allocation, what does that look like now as we start to say BHSA and we move to this July 1st deadline? So first, innovative projects are still possible with funding, but they're no longer their own area. You can kind of see that those are now fed into that yellow box that says INN, innovation, now feeds into this larger grouping of behavioral health services and supports. What used to be community supports and services, which included things like outreach and direct services for serious mental illness for all ages. Half of the CSS funding that was there before, so this community support services, now go to full partnership programs. So you can kind of see these arrows going two different ways. And some of it is going into housing and behavioral health services. So we've had kind of a redistribution. And if I didn't say this at the top when I talked about the change, this redistribution isn't necessarily new money, right? This is the same amount of dollars that we were starting with MHSA, but the funding allocation of it and how you have to spend it has changed. So you'll kind of see.
If I may just jump in very briefly, it is actually less money. It's 5% objectively less money than we had before, because the state has retained an additional 5%.
Yes. No, that's a great point, Elise. And that's what Elise is highlighting is on the slide here with MHSA, 95% of those funds came to the counties. Now only 90% of those funds are coming to the counties. And as you saw, there are many more components that the counties are being asked to do with that. So there is a change there. Thank you for highlighting that. And I think that's actually a great transition to looking at the actual integrated plan for Lake County and seeing how those transitions are impacting locally and what that looks like. So just to start, again, we've mentioned this a couple times. There is a Behavioral Health Services Act webpage, landing page, if you will, on Lake County's website. You can get many of the plan attachments. You can get these slides. Previous community planning meetings where even more of this was detailed are recorded in there, so you can dig in a little bit more as you'd like. And draft plans, eventually, finalized plans. This is a place to kind of look to for those resources. And then thinking about the integrated plan, here's a slide that shows what are those core sections, right? It's an extensive document. It outlines how Lake County will use and allocate the behavioral health funding and provide services over the next 3 years. Today, though, for time and just what is that impact, we're really going to be focusing on the final 3 areas, right? How has the budget shifted? What is the budget proposed and the support programs and services that pair with that Lake County are putting forward, as well as what's driving some of those proposed changes. And so I'm going to hand over to Scott to do a little bit more review of budget changes and impacts and move through what that looks like with support programs and services. So Scott, I'll let you take over at this slide.
I know Scott is at the center and I actually don't mind stepping up to take over this section just because it may be more difficult for people to hear him while he is at the center. So I really appreciate this slide. This is about as simple as I think you could possibly make it, which really speaks to the complexity of the change that behavioral health plans are navigating. So, of course, on your left, you'll see the MHSA Community Services and Supports, which includes all of the service categories you've been accustomed to seeing historically. So, of course, we have our full service partnership. Within that full service partnership, we the plan paid for a significant amount of housing. We also had this category called general system development. A lot of that we actually used for short-term housing stays for individuals who might not have been enrolled in services yet. A lot of hotel stays were purchased with this, particularly to support individuals and services during periods of inclement weather where we were concerned for them. Also, our MHSA housing coordinator to help that. Housing and homelessness related outreach was a significant component of the prior MHSA plan. And then we had other kinds of outreach. There was also going into that, you can see the big categories right in the center, which is our full service partnership. Those are all the new BHSA funding categories, and you can see how we're trying to map the old to the new. And so on the right-hand side, you'll also see this important category of prevention and early intervention. So that was housing and homelessness related services, peer support centers, and a bunch of other prevention services, notably things like the Motherwise program, Kanaktai senior supports, to name at least two types of services that were funded over those contracts. And so you can see from both the right and the left columns that we have had to condense significantly those programmatic elements to fit within these new funding buckets. With no new funding, and as I stated, in fact, 5% objectively less funding. So the category of prevention and early intervention has completely been eliminated, and that, as you can see, may in some ways be subsumed by this broader category of other behavioral health services and support. So essentially, all of the funding for things like the peer-run wellness centers, for our variety of outreach with the PEI side, as well as a lot of the other community services and supports, are now condensed into a much narrower funding budget. And that is the reason why we have had to move towards closure of the peer-run wellness centers, is because it was simply not covered within the new BHSA funding category, and we're required to provide funding to a variety of other services. Yeah. Okay, so this is looking at our previous fiscal year, fiscal year 24-25 expenses and how we're estimating our BHSA funding allocations. And so this slide illustrates the structural shift, which is pretty dramatic. So you can see that the three buckets in the BHSA are represented here, which is full service partnership, and that's the reddish columns on the far left. In the middle, we have housing interventions, the green, and on the left, we have behavioral health services and supports programs. So those are spread pretty cleanly, evenly. So we'll start with the full service partnership. We know that our expenses in fiscal year 24-25 for FSP were about 1.3, call it almost 1.4 million. And the new funding allocation, we must attempt to spend close to 2 million on full service partnerships. Importantly, under the new BHSA, or rather under the old MHSA, we provided a lot of housing, like paying rents and things like that under FSP. All those expenses are now going to shift into the middle column, which is housing. So in 24-25, we had a lot of housing expenses, over $2 million, which included rents for long-term permanent housing, as well as a lot of hotel rooms. Just that happened. There was a lot of inclement weather we dealt with. And so that was a lot of expense. We're seeing that that's going to be a reduction from our historical spending within the new allocated funding. So there's a delta or a gap there between what we have historically spent and what we now have to work within. Getting over to the behavioral health services and supports program bucket, this is the most dramatic difference, I would say. You can see that there was a variety of programs that encompassed our PEI programming that is blended in with crisis services, with outreach and engagement, with funding of the peer-run wellness centers. So in 24-25, we spent almost $3.5 million between all of these services. And now we have to look at condensing these services into about half the amount of funding, right? And so you can kind of map how the peer-run wellness centers was one thing that was identified as not fitting within the parameters of the new funding allocations. And so that was the primary driving decision maker here. That's where we ended up. Okay, so looking forward and projecting our budget. So this is our proposed funding. We have significant portion to BHSS, as we've discussed. So it's important to note that, as the slide states, while the statutory framework allocates 35% to FSP, 35% to behavioral health services and supports, and 30% to housing, we are requesting a transfer of 3% from FSP because, as you can see, we are spending historically below what we're allocated to our behavioral health services and supports category, which obviously is underfunded relative to the programmatic history. So that will mean that our biggest category is that behavioral health services and supports at 38%, followed by FSP at 32% of the total funding, and then 30% for housing, for a total of nearly $7.8 million.
Yeah, and I apologize. This is an oversight on my part. I want to just note, this includes some MHSA carryover, and we didn't put that asterisk in for the BHSS. So if you're kind of doing those numbers, I know you have the full budget you'll get to see in the plan, but I apologize for not noting that on the slide.
No,
That's
thank
where
you. That's a
see
great
that.
call out. I was also, yeah, so we did have a carryover, which is not uncommon at all from our prior MHSA, that it's kind of going to be one-time funding going into behavioral health services and supports. It will not be looking like this in perpetuity for sure. Thank you. Okay, so these are our estimated funding expenditures. Moving on into the future, costs are remaining relatively stable. The budget is remaining relatively stable, which is a nice outlook. Just reminding everybody again that this funding is a direct result of that 1% tax on California's wealthiest individuals. However, it's a significant amount of volatility, as you can imagine, depending on how many wealthy individuals are in the state of California, right? What the budget, what the global financial picture for the state of California looks like. But this is it's generally, these estimates tend to be pretty solid. So we have pretty high confidence that that's our funding looking into the future. Okay, So again, we're gonna take a deeper dive into the new BHSA funding categories. So as I said, we have our full service partnerships as part of Proposition 1, which passed in, gosh, time flies, a couple of years ago, right? And it requires us, in addition to the BHSA, it's also this idea of behavioral health transformation, where the state really wants us to modernize, so to say, the behavioral health plan. And so as part of full service partnerships, we're now required to provide what are called evidence-based practices. So these include things like assertive community treatment, which is a way of really providing a lot of support to our sickest patients, our sickest clients. Forensic assertive community treatment, which means providing a lot of support to people who may be involved in the justice system. Intensive case management, we're also required to provide high fidelity wraparound to youth who are at risk of out-of-home placement in order to stabilize them in the lowest level of community-based care. Also, supported employment is a new program that we will be required to lift. And also, this is really exciting, assertive field-based initiation of SUD treatment services. What does that mean? That means that we literally go out into the community, wherever, like parks, parking lots, wherever we can find a place, and we deliver right there, right then. If somebody wants and will accept SUD, substance use disorder treatment services, including and up to medications, at that moment, we have to provide it. We've been planning, we have some kind of exciting things coming to fruition and that I'll hopefully be able to share in the future. And of course, operating costs. So it's important to note that each one of those evidence-based practices is a highly rigorous, highly monitored fidelity model. And the state is paying very close attention to making sure that counties implement these practices to a high level of fidelity. So that's also part of the rationale for the change in the funding buckets as well. The housing interventions, which we've been doing all of this, but now it has its own category outside of FSP. The rental assistance that's we've been doing for years, having a housing coordinator, which we have, street outreach and kind of engaging those are included in this housing intervention category. And up to 7% of those funds can be used for housing related outreach and engagement. So, going out again into the community is something that is really highly prioritized within the Behavioral Health Services Act. And we've heard that pretty loudly from our community. We have heard over the years since I've been here, hey, we'd really love you to come to us. While it's great to have brick and mortar facilities, the community and the state is asking us to penetrate more deeply into the community where people live. So the last category we'll cover, which is our largest bucket of funding, is that behavioral health services and supports category. So 50% of this must be allocated to early intervention. So the state very wisely has said, hey, an ounce of prevention and intervention is worth a pound of cure, right? Which we all know. So we are looking at continuity for some of our peer-run wellness centers transitioning into peer support recovery centers. So one of those is a forthcoming request for proposals for a transitional age youth clubhouse. And you also see a Bridge of Hope clubhouse. The clubhouse is a model within a separate framework called Behavioral Health Connect. And I'm not going to spell out, that's an acronym actually. So it's a different model. It also requires a lot more fidelity implementation. It's much more formal and I would say rigid than our historical peer-run wellness centers have been. So we're gonna do our best to look at what we can do to lift those. We also are investing in early intervention services. We have had a coordinated specialty care program for first episode psychosis for a few years. Actually, it started off, as a grant funded program. And now, lo and behold, we're required to provide that. What is cool is some of the early research, or all the research has shown that if you're able to intervene with individuals experiencing their first episode of psychosis, which statistically happens between the age of 13 to 21. Oh, thank you so much for that. If you intervene early and well enough, you can have nearly full remission in some cases of a psychotic disorder. And for those of you who may not know, psychosis and psychotic related disorders are a very serious behavioral health, physical health actually condition. And so we're investing a lot into that program. We also are looking at a Native American early intervention program, again, to reach those youth who may be experiencing behavioral health challenges and to kind of help them get on a healthier and safer developmental trajectory to avoid sickness and costs down the road, right? We're really trying to get in there early and effectively to prevent suffering in many ways. Also a parent partner. So we know that especially with youth, parents and caregivers are a significant driver of recovery and demands their own support. And so we do presently have a parent partner who we're working with that we employ, and we will be continuing to embed that individual into these models of care. We will also fund outreach and engagement, workforce education and training for our staff, contracted providers, and interested, relevant community members, recognizing that training is really important for developing overall workforce capacity. Of course, we have capital facilities. What does that mean? Like brick and mortar. So we have our clinic in Lucerne. We have our clinic in Clear Lake, right? Obviously, any healthcare organization has a lot of technological needs, and computers last all of like 6 months. I'm kidding, but really, like the lifespan of technology is pretty short, and so it requires a high turnover, which means expense. And then some room for some innovation projects, which we can talk about later. Okay, so for looking at our inaugural 26-27 BHSA program, obviously there are significant modifications, and all 58 counties across California are grappling with how to approach these changes in funding and how to align program within the funding. That has, unfortunately, as we're all well aware, resulted in the need to restructure our peer-run wellness centers. So we have already begun the consolidation process and redesigning these services to be consistent with BHSA requirements. And also the state has really focused counties' attention on services that draw down Medicaid reimbursement through federal financial participation. They have really said programs should ultimately try to be sustainable through Medi-Cal billing. So as I stated before, we have consolidated our centers into two. The Tay Clubhouse is not yet established. Like I said, a request for proposals will be forthcoming for those services. And we are in transition now for a new center in the Clubhouse model. And if you click that BH Connect link, you can learn more about all what that is. But that is hopeful to be opening in Clear Lake at the site where Laveau's has historically operated. As I said before, we've got to integrate a lot of evidence-based practices, and these tend to be very challenging from a workforce perspective, as well as a training perspective, as well as every perspective, actually. So unfortunately, there are programs that we are not able to fit within our new guidelines, which is postpartum depression screening, our older adult outreach and prevention, and as well as our prevention mini grants. Okay, so we have done our very best, recognizing that these are dramatic shifts for our community. and the needs don't disappear because of these shifts. So as I said, expanding our FSP to do these evidence-based practices, restructuring and consolidating our formerly peer-run wellness centers into hopefully an attempt at this clubhouse model. Really integrating. So it's important to note that some counties across California were perhaps not as well positioned as Lake with regard to integrating their existing peer staff who may have been at wellness centers into clinical teams. We have made an incredible effort and have been successful in our peers becoming certified peers. So what that means is they're eligible and able to bill Medi-Cal for services, but they have to be within the context of clinical teams. So that means that with our assertive community treatment team, for example, we need a peer. Within our first episode psychosis program, we need a peer. In fact, all of our programs could benefit from a peer. It is quite a transition, but again, we have a robust staff of certified peers who are presently, right as we speak, in this moment, we've been working through training and integration into our clinical teams. And as I stated before, big focus from the state on sustaining programs through Medi-Cal billing and attempting to generate revenue. Through our housing, we will hopefully have an expansion of street outreach services within the Lake County continuum of care. I know that Melissa Koff, who is our program analyst for the Lake County Continuum, is here. So hopefully she'll be able to answer any questions regarding that. Also, I'm aware that the supervisor Spatier is here, who also serves as the chair of the Lake County Continuum of Care. So we have some great subject matter expertise in the house for anyone with questions about that. But generally, our marching orders have been, how do we explore opportunities to strengthen and build partnerships and determine where stuff that we do may be in some ways duplicative, where we can align with other organizations to help sustain some of these services that we're no longer able to carry. Thank you. Woo, this is a doozy. So we have a lot of strategies that we have identified to address the community needs. Service awareness, outreach, and access. I want to give a special shout out to Miss Megan Morgan, who has done an exceptional job over her couple of years, I think, only being with the county on really enhancing, there we go, our social media presence and engagement. We have a beautiful department newsletter, but recognizing that community-wide engagement, and especially through social media, is really critical in this day and age. Really making an effort to be present at community events. Please, y'all, also turn into Recovery Radio. It will be airing today at 2 p.m. as it does every Wednesday on KPFZ, our local radio station. It's most excellent, and we have some wonderful MC, what do they call? I don't know, DJs. It's really fun. We also have suicide prevention and awareness health fair at a local community college. So really, where can we embed into existing events and structures in a way that aligns with our, the lane that we need to stay in? We want to continue to support mobile crisis services. That's kind of a hot topic. Some of you may or may not know that the governor's revision to the state budget comes out today. At any moment, it could have come out already, I don't know. And mobile crisis has been a big focus of that, and whether or not the state will continue to provide funding support to county mobile crisis programs. So more to be seen about that for sure. Mobile crisis services. Oh, yep. Thank you, Carrie. Thank you. And the peer support centers, doing street outreach, really important. Again, going to where people are. We hear you loud and clear. We are continuing to refine our access process. really closing that loop, making sure that people don't slip through the proverbial cracks, very important to us. So for service coordination, we have a lot of different strategies that we've identified to better coordinate services, partnering with other community agencies, developing partnerships with other county entities. For example, if you don't know, we do share a facility in Lower Lake with our probation department, where we do a lot of work with them around their population that they serve. And so it just made sense for us to kind of live in the same house and make it easier for people, kind of a one-stop shop. Our centers have also been access points for coordinated entry, which is a way of saying getting access to like things like HUD and housing supports, and improve collaboration between our peers and our clinical services. So we've been also working really hard and recognizing that tribal members and in general continue to be underserved, as do all non-white people in our county, which is not inconsistent with the state. So really having a concerted focus on how we can better support those populations, including forthcoming requests for proposals for a tribal wellness center. As I've said a lot about the peer-run wellness centers evolving into potentially a clubhouse model. And then for workforce, which is critical, continue to invest in developing our people, training them well. We have a lot of success with scholarship programs where some staff I know have not paid anything for up to a master's degree, which is really exciting and good. We also have some facilities issues, like for the longest time, we were still using a physical key to open our doors. We finally have a little a badge, I don't know what they call it, that you just touch it and it opens, which I love it. So we're kind of like coming into, the millennium. And then of course the remodel of our Clear Lake Clinic, which is a really big project.
Thanks, Elise. I can jump in for these last few, but as you have heard from Elise, there has been a lot, I guess the better word is probably a significant amount of engagement, listening, planning, considering how to develop this integrated plan to meet needs and the state requirements. And so just wanted to resituate where we're at in the process as we close out the overview. But following today's meeting and the discussion that is here and any of the public comments that were collected, there'll be a period of bringing all of those comments together, looking at those in addition to ongoing feedback on the draft plan from DHCS. And then eventually the final plan. So that will all get updated into the draft that you have now all seen. A final integrated plan is required to be presented to the Board of Supervisors. So that will happen in later June. And then the integrated plan is due back to the state on June 30th. So that is a statewide deadline for all counties. And then again, a reminder, you can find these slides to look back on, go into deeper resources all on the Lake County BHSA website. And again, on this slide, if you even find these slides, you have a lot of quick links to just general and more information about the BHSA transition. So I think that ends here. Elise, is there anything else you'd want to say before we hand it back over to the Behavioral Health Board?
I don't think I have anything.
All right, thank you. Well, then we'll hand it back over to the Behavioral Health Board for discussion and the other pieces of your agenda. Thank you.
So thank you for that very informative presentation. Do we have any discussion on what we just learned? Yeah.
I have a question. On the Native American early intervention, I'm just wondering what that looks like. Like, where would that be focused? Like what, and like what area, Clear Lake, Lakeport, where is
Yeah,
that?
so that would depend on who applies. So we recognize that for a variety of reasons, it makes more sense for the community and probably a tribe, either a tribe or a tribally based CBO or entity to offer those services. And so that will be dependent on the outcome of the request for proposals.
And what is the total funding for that?
That's a great question.
It
I
is
don't have it.
$100,000 a year.
Thank you.
Thank you.
Proposed. So I have a question regarding, the requirements for some of these locations, and I know that the big push for the state, well, and everywhere, is pushing Medi-Cal funding so money can come back into the communities by services provided instead of just being paid by our taxpayers dollars and being able to pull some of them from the federal government. But how, I mean, are these agencies and locations going to need to be accredited and approved by Medi-Cal system and underpaid? Are they going to be still run as, like kind of what's happening with the, some of the ECM and community sports situations where there isn't a whole lot of, oversight or situations addressed with credentialing, funding opportunities, or how it's regulated, it's required for certification. Okay, I mean, I don't know, like, for me, it's certified, licensed, there's differences. So some of this is the same, but very different. Stuff that we've been required to do and mandated forever is now, it appears to be what the parity is and required. And they're required, I mean, probation is gonna be an ECM provider. That means, are these gonna be eventually required to have Medi-Cal certifications so they can get reimbursable funds?
So the question, I think, is the $100,000 that's allocated under that funding stream, does that service get billed up to Medi-Cal? And if it does, I think we can generally answer that question.
For that particular service, we're not looking at doing that. However,
Peer supports of the children.
for the Native American.
Native American, okay.
Right.
So the Native American, but for the rest of it.
Right. But you bring up a really good point. The idea is, with the funding that we have, especially because it's been reallocated and as Elisa explained, it's limited to us in a certain number of ways. We want to maximize as much as we can the usage of it to gain more FFP, federal portion.
Yeah.
From Medi-Cal.
And doing that, I will just say that the thought of more work coming, again, April Gambra, the thought of more work coming down with stricter regulations does not always feel good. But I actually sleep a little bit better at night when I do sleep, knowing that we will have to be more accountable for those outcomes. If I pay somebody to do a job, I want to make sure that that job is getting done, right? And this really holds our feet to the fire and shows that when we provide these services, they're working, right? There's data to support that. We have to do that. And going forward, transitioning some of the services over into these funding streams will require us to do that. The more accountable we are, the more we bill, the more money we'll be able to have, in theory, to be able to expand services, right? So it's a hard shift for a lot of entities, including our department, but we're 100 in support of it because it gives us a place to grow to, right? So I just wanted to say that. So with that comes more accountability. Was the summary of that. And that means that all of our services that draw revenue will have to follow the same monitoring and compliance issue. So the rest of the county, I have no idea, Lori. I just know that we go to.
My understanding, so for us, when we started talking about parity and everything, it's kind of funny because when I pulled this out, this is my BHCS stuff from 2022. So, and when they were dealing with some of the changes, and I didn't even realize it addresses the peer sports and clubhouse models as well. But we have already substance use providers have been strictly regulated for years. Matter of fact, when partnership talked about leaving the regional model, they reflected on the hyper regulations of substance use and their reasoning for abandoning the situation. But the reality is parity means that the rest of everybody else is going to have to step up to the plate with us. Yep. And that's what I'm seeing. And so I guess that's why. So and the requirements, I mean, to address budget shortfalls and everything else, agencies that used to be just paid for by taxpayers' dollars are now going to be forced to create its own revenue to survive.
Yes.
Right, which is something substance use has always had to do. So I was kind of missing and not understanding some of it, but I didn't realize in areas, and even in different counties, because I'm contracted to Sonoma County, they had substance use programs that were not certified and did not capture any dollars for years. They were just getting paid by taxpayers' dollars. Then it was mandated. So now it is costing the federal government more, might take some things away from the state. But how is it going to reflect everything with the agencies that don't understand that that's part of what's missing? I mean, probation is going to become a provider. And if, I mean, and then I'm not even sure where they're going with the regulations with that, but I do know under the managed care plans and that a lot of it isn't being as regulated as it's supposed to. And I believe that there's going to be a shift in that changing as well. So where do we get from where we are now and the problem is with all those cuts to making these agencies be able to sustain by creating their own income? Because these are billable services for what I see. We have peer support specialists and workforce and outpatient. That is recouped through Medi-Cal funding. They pay for basically their positions.
I think where we start is by doing what we're doing, by making our peer support centers in some degree billable so that they can be sustainable and transitioning to a clubhouse model or a billable model. And then pushing that out, asking everybody else for that support to follow that so we can be accountable and generate more funding to be sustainable.
Because I listened, I saw with me some of the budget stuff and the shortfalls. And where they cut. They put things that don't make sense to me at all. Give more money to places where there's less regulations, where the money just goes out and it's crazy. And the stuff that needs to be done, they're taking away from. I mean, I was a firm fighter in why you guys had 2 weeks off at the end of the year when we had more crisis. Now, I mean, I complain about it all the time. Now, mobile crisis has made a great difference. Why would that be cut? Why would the governor think that's not necessary when it's made such a big difference and allow agencies that don't follow through or be accountable? And I'm sorry, I say this directly to partnership and they know it, but they are not doing their due diligence and addressing things when stuff is being funded without even seeing if people have the right credentials or if they're even correctly addressing their obligations. And then, you know, I mean, sorry, I'm ADHD and I got a little lost. Then finding, I mean, how we're gonna get it to work here. Like how are we gonna teach the people that don't even realize that they are doing billable services and get it to that level? So we can keep things like mobile crisis and peer support centers, however that looks, to make it work. Or, you know, if it's the clubhouse or whatever, and this is actually in the thing from DHCS a few years ago, is the clubhouse models. So wondering how we can make it to where we are now sustaining based on doing the services that have always been done, making them billable, and how that transition is going to happen. Instead of us staying stuck and fighting who's not getting what done, how are we going to do it, improve it, and make it happen?
Thank you, Laura. I will just add one comment and then I'm going to defer to Elise or anybody on Zoom that would like to say anything. But for me, the idea of bringing everybody together rather than training across the county, consolidating resources, kind of doing a couple steps back to really training us how we can do that together as a team, and then re-envisioning and redeploying back out into the community, not having a thought of ever staying in one facility. Our community needs us. And then going back out, but we have to kind of pull it back in to tighten it up to get stronger and better, and then roll that model out.
Thank you.
Thank you.
Tammy has something to say.
Tammy Rust, board member. It's a different topic than that, but my concern is the dismissal of funding for postpartum depression. I'm bringing that topic up as a daughter whose mother completed suicide from postpartum depression. So lives do hang in the balance with that. That seems crazy to me that that's being cut. Is there any other help in this county for that if it's not coming through this funding?
Yeah, let me clarify. So that funding from the MHSA for that particular program was a direct contract with Motherwise. Motherwise is still an entity that exists. Now, to the extent that they can mitigate that budget impact, you know, that will be on them. And it's also important to know that public health has a maternal, child, and adolescent health program. Sutter Hospital is also very invested in postpartum screening. So I don't want to imply that there will be an absence of that service within Lake County. It is just something that we are no longer directly funding.
Just wanted to hear that there was a safety net, or I was gonna lose my pick of her. Yeah, thank you.
I have something I'd like to say. So now it looks like services are primarily going to be over in South Lake area and North Lake. Is there any plans for any kind of services that are focused out of Lakeport? Because there is such a high need here as well.
I can take a little bit of that.
Okay.
So currently within the county, the infrastructure or brick and mortar is very limited. Of course, we don't own buildings, and so we're trying to navigate pulling those resources. What we are and would like to do, and what is part of this whole change, is we must get from behind our desks and out in the community.
Yes.
And so that means that our case managers, our service therapists will travel around wherever we need to go. We have to get out. That's the barrier, asking people to do that unreasonable transportation and coming to our offices. So we have to push ourselves out there with a team of qualified professionals, right? And those that are lived experience and can work alongside to help me to get good services. Yes, so that is the only answer at this point.
Yeah.
5 years, I'd like to see us have a clubhouse in every city around the lake, but I dream big.
Well, I just went to the state board meeting and they said the clubhouse model, because I've talked to other boards and said it was very, very effective. So that was.
That's good to hear.
Yeah.
Thank you.
Can I just ask one more question? How many people can be served in the clubhouse model? Do we have a number or do we know yet or?
I don't have an idea. That's a great question to ask. If someone could take note of that, I promise to send out some updates on that for sure.
Thank you.
Appreciate it.
I have a question. Can I say? I'm Ron Montez, Charles Elder from New Valley. If you're looking to go out from behind your desk to where the people are in the Native community, you're dealing with issues that you guys don't know how to handle. You've been trained in a particular manner that does not address those things which are carried by Native people. And so I don't think you have trained people to do a good job on that.
Wow, right.
That is something we have talked about in our Pathfinders group, to bring that training to Native people to serve their own people.
Yes.
So
yes.
we need to get our own people trained with what's the basic requirements. And they have that other added information because they lived it. And we have elders still available that can share those intimate things that's tied in with our culture and our way of life that has been passed down for years and years and years, which they won't open up to anybody. There's a barrier right off the bat. Unless you're a Native person that they can recognize and they get to know you, then they can open up. Otherwise, you're just going to be spinning your wheels and they'll have the same problem. So.
Thank you for that. 1000%, if I may. My husband is also an elder, and I learned sometimes when to keep my mouth quiet, but I really understand that approaching that as though we can is a bad way to do it. We need to listen to know how to support, not even throwing support out, but be present to listen and open to receive it and how we can support. We should not be the ones doing that. I agree.
I have a question. Do we have any certified peers that are Native? Have we done any kind of recruitment for like Native American peers, like local?
Our tribal communities are really boosting up. They are doing a lot. They are opening centers, their own social services, they're opening up their own justice programs, their own youth wellness outreach. They are doing a lot, and all we want to do is to support them. That's it. And so, Elise, if you could please maybe add any projects that you know that we have with funding attached to them to support our local tribal communities.
Of course, and I appreciate Elder Montez, your perspective, and I agree with you. And yes, that request for proposals for tribal wellness is based in that that ethos that it's most ideal and most helpful for tribal people to serve tribal people. And to the extent that we can support capacity development, we do work with, we have a contract through our opioid settlement funds with Kanokatai Native Wellness. That's a start. It is not an end, but it actually has been one of my top priorities since I took this position. And so your comments are well received.
I would just like to make one statement. Elder Montes, I'm Laura from Hilltop Recovery, and we were discussing some things with my employees recently when we realized we actually have 9 Native Americans that work for us as part of, and of my peer support specialists, which I have 3 of, 2 are Native American. So I just wanted to make sure that, I mean, it is something that, and one of the things that we've always brought into Hilltops is asking, acknowledging we know nothing about what you went through, so please teach us. And it's been something that's really worked. But when asking about recruiting, I didn't even realize that was our population at one point until we were discussing some of those things, and realizing it's something that helps make a difference as well. So, and understanding how little we know, but then realizing, wow, we already have this happening here. So it was just something that, I wanted to share that has made a difference, and I see and I understand that, even though I don't personally understand it.
Yes, well, if we can kind of consolidate the resources that we have and the availability.
Right.
And get together with Kanokatai and all this, we're gonna kind of work together in a lot of these areas. Because we've seen this for many, many years. And it depends even in the Native arena who you are. Because
yes,
they have been hurt for many, many years from their own everybody. And it's very hard to get that breakdown to actually get a trust built. But once that is broken and they have that trust, they open up doors to their families and friends. So it opens up that it's safe here. You can come and you'll be treated right. And until that happens, it's locked. And so that, with those people that you may have, if they have those skills, those stories, or they're tied in cultural wise. Now that's the big thing now. So if you know your culture and your history here in Lake County, it gives you an edge because many of us have been raised in this vacuum where nobody else except us know this stuff. And when we talk about it, it sounds like we're condemning you because you're white and we're anti you and so on. That's not it. We're trying to find a place where we can access communicating with health and healing as the motive behind it. So until we can get to that place, it's just few of us out who travel in this area and this whole area of that healing of the different groups, communities. And so right now, there's just a few people who have a recognition and thankfully, I'm one of those people. And I didn't ask for it, it just seemed to happen. But anyhow, so that is a reality that we have in the Native community. And it's been way past time to really address it and help. So that's my 2 cents worth for today.
Thank you.
Yeah. Oh.
Hi, I'm Raven Shepherd with Lake County Behavioral Health, and I am Native American, and it's good to see you, Ron Montez, and a lot of familiar faces. One thing I want to say, I mean, I think I need to say something about, you know, tribal communities or being Native American, since we're talking about this, is that like oftentimes, you know, throughout even as a child, we've definitely heard a lot of the discussions that we're having today since I was a child. And, you know, it's nice to have people listen. However, taking action or creating some sustainability with Native American communities or Native American powerhouses or Native American leaders, you know, that is where the work would be at, is sustaining those types of relationships with tribal leaders in tribal communities. And so there's a break. I feel like there's a gap in that service, or there's a breakdown when it comes to long-term sustainability partnerships with tribes, tribal communities, tribal leaders. So that's when the work really starts happening. It's about when people say, you know, other people should be at the table and things like that. I mean, that's something we've heard for years and years. And like, so it's like nice that people are listening. However, like tribal communities are tired of talking sometimes. Like we're hoping somebody takes, you know, takes some action and some sustainability, and being, you know, holding selves accountable for not holding that sustainability. You know, and that's where it gets tricky. Like me as a Native person, or I know within our tribal communities, we talk about like, okay, accountability, policies, procedures, what does all that look like? For us, our natural law of order or our way of doing things may be a little bit different politically when it comes to policies and procedures. So when we look at policies and procedures, we may not be looking at policies and procedures from maybe a Western perspective to understand it that way. That doesn't mean we're incompetent to understanding like, oh, we're supposed to do it like this or like that. I bring this up because there's always a lot of communication breakdown, and then that falls back on, like, it trickles down to all of the people that are being harmed by us not being able to communicate substantially long term, being like having that long term support and things like that. So I just wanted to say that. I just want to say also, like, Lori brought up a good point about she employs 9 Native American, like 9 Native Americans at her center. And that wasn't something that just happened overnight or was in the last year. That's something that's been sustainable for I don't know how long. However, it's been multiple years that she has been employing Native Americans. So I just wanted to bring that to our attention too, and speak my piece. Thank you.
Have any more behavioral health or response and discussion, or ready to move on to public comment?
I'll ask a question. So obviously the focus for BHSA is housing, which if it's the same amount of money minus 5%, that's a really difficult task to take on because building houses here is difficult. There is a new program that I don't understand, but it's in the BHSA. It talks about that we're interested in doing it, but then there's $0 allocated to it in the 3 years. Can you talk about what flex pool housing is and why is it that we don't have any money allocated to it if it's, I guess, if it is a potential tool to help us in getting housing into Lake County?
All right, is that within the transitional rent benefit?
It's its own component. It has its own portion called flex housing, or flex pool housing. And under the budget where it shows flex pool housing, it just has $0 for the next 3 years, even though it does say that there is interest to move forward with flex pool housing.
So I can address that. Flex pool housing is designed it's a state design where kind of like what it said, it's a flex pool. It's the idea, and what counties have usually done over there, it's been done by bigger counties where they'll contract with an entity that will take the different funds that the different agencies in the community get for housing and kind of combine them together to be able to distribute, from that flex pool. And that is something that we are interested in, particularly because we're the administrative entity for the COC. So it makes a lot of sense. But it also has a lot of requirements to go with it, which we haven't yet developed. And as Elisa's mentioned, and you mentioned this now, the bulk of our housing funds are dedicated into essentially kind of maintaining what we're doing. And so we don't really have any additional funds to contribute to that as yet. But the idea is, that eventually, and most effectively and efficiently, is if we can kind of what the COC does is the funding that we can get is if it can be used efficiently across the entire community.
And so does BHSA work like MHSA that every year we revise the budget? Because I believe that's what would come to the Board of Supervisors to approve. So it's possible that for year 2 and year 3 that we do see some funding being allocated for flex pool housing if we are prepared for joining the flex pool housing.
And a big part of that, as you can imagine, is the organizational ability to do that. Because it's gonna require obviously personnel to do that, to be able to manage that flex pool.
Okay. I was looking at the past MHSA costs. I think the last one I found at the state level was like 23, 24. I don't know that I saw the 24, 25. And I believe it was like, I don't know, 30% of the total amount between all the programs, the CSS, the INN, and the, whatever the third one was. But about 30% was for planning and administration. Is that approximately the same percentage that is anticipated here? Or is it
for planning administration of housing?
Of MHSA.
Oh,
like the whole MHSA, when I looked at the breakdown that was at the state, there was line items for like the programs and the services, and then there was line items for planning and administration. When I counted up the whole thing, about 30% was for planning and administration. I'm wondering if that is still approximately the same breakdown that BHSA allows us to do, or are they lowering what is allowable in the planning administration and more into the services? Just kind of wondering what the ability of the restrictions are.
They have kind of altered, how the funding is used. For example, they put a cap on only 5% can be used for administrative costs. When we were using MHSA, we used a whole different, measurement of how we did it. We included indirect costs as well into our administrative costs. Now they're very strictly separating that out so that, this 5% comes from administration also includes community planning, and that's why I bring up the planning for future programming comes out of that 5%. But we do have room now within each of the categories that are left for indirect costs. For the likes of, the things that keep things this running, we can now include those, where before we kind of those administrative costs.
Gotcha.
Right.
And you were saying something that triggered, I'll just go to my next question.
Okay.
One of the weird statistics I saw in the BHSA, maybe it's true, but it just blew me away. It was asking for data points from, I think, the past year, if I remember correctly. And it said that you engaged with 5,001 incarcerated folks. Like, that seemed like a really large number. Or I think it was a probation and maybe PCRS, or it was, I forget the specific title of that, but it was 5,001 Everything else was like less than 11 or like a number that was like, okay, that seems right. But 5,001 seemed either not unduplicated or some other number that.
It was an error and it's been corrected in the revisions with the Department of Healthcare Services. It should be that we increased that contact by 50. It should have been, there was like a 01, so it's a way less number.
Okay.
But I will say that we currently do have 250 JI on both clients, but yes, that is way off.
And I don't remember the question that I had when you were responding. So, sorry. No worries. That was on Scott. Sorry.
Thank you.
Yeah, next question. My name is Lindsay. I'm a reporter with Lake County News. I have several questions. First one, I want to know more about those previous programs no longer funded. So I want to know more about these programs: postpartum depression and screening program, our adult outreach and prevention program, and prevention living plans. I wonder like how many people are affected and what's going to happen about those programs.
I can speak a little bit about the outreach and senior supports. That program is funded separate and apart, but now it's inclusive of our other programs and services. Okay. So there will be a peer support specialist trained, focused in those interventions and responding appropriately to that population. And that is a theory with all of them, is that we really honed in on increasing our subject matter expertise in those areas and really, conforming to that population's needs. As far as Mother-Wise, I think Elise already alluded to that. We are a portion of those funding programs and services. And so I believe that there is still other opportunities. I know that there are other grants that focus more on the medical models. I know that there are additional funding coming out for some areas. And then as far as the mini grants. Okay.
The mini grants with a small amount that we had funded, it's about 25 to 30,000 for $2,500 a piece mini grants that different community agencies and interested individuals throughout the community could apply for. That would, for an event or something that would help with, better mental health. And so it's not a lot, and it's just one of those things. Kind of before was kind of a luxury that we could do, and we just, because of the changes that Elise talked about, we just don't have the ability to do that now.
Thank you. I'd like to further clarify, and I don't know if you have access to our Teams chat. However, I have put a link to the Department of Health Services, aka Public Health in Lake County, does operate a maternal, child, and adolescent health program that includes home visiting, child well visits, and immunization. And so I want to be very clear that because we are removing one quite small funding stream that was contracted out with Mother-Wise, supports for mothers, pregnant people, and postpartum issues still exists in Lake County. Also, we did provide a very small amount actually to Canocti Senior Supports, which will continue to exist and provide services. So those services also, it's important to note, the state has said, hey, behavioral health, you really need to stay in your lane because there are other organizations in your community, and some of this work may be duplicative.
Thank you. I do have one question. So those services too, are those also possibly Medi-Cal billable where it can be recouped so they can sustain?
Yes.
So is it the agencies don't know how to or not?
I couldn't speak for public health. I don't know the extent to how those programs and services are funded. I just know that they exist.
But are they Medi-Cal, can they be Medi-Cal, recouped by Medi-Cal dollars? If they have the services in place and they have the right certifications or requirements in place, are those reimbursable expenses?
They may be, but not with behavioral health.
No, I'm not talking about behavioral health for the other agencies. I'm looking at how the other agencies can jump in and be responsible. And figuring out their parts as we're discussing working as a community, getting grants. Again, substance use has had to fight lots of battles and Hilltop has as well. So I didn't focus on what I was getting locally. I found the way to sustain by doing the work and getting billable services and making us maintain on our own. So are these other agencies allowed to be billing Medi-Cal services? What does that look like? How can it be done, and how can we help the other agencies that are already providing the services instead of having new ones come in that don't know our community, and have them help get to where they're able to recoup the funds as well, where they're doing the work and those are billable. And that way, not everybody is dependent on the county or the government paying us, because we're doing the services and we're getting paid and wanting to sustain on our own. Again, I mean, therapy services are things that are recoupable in one way or other if they're Medi-Cal providers. Is it that we could have more Medi-Cal providers for the people that are already doing this and help them get in line with being able to get the funding themselves instead of counting on the county or other agencies to cover them and keep them going? Is those, I mean, I'm just asking and looking towards solutions. Are those things that are possible?
So I just wanted to add, yes, Lori, I believe that's what we're doing when we talk about absorbing and offering those services to our senior partners and elder populations, is by pulling them in and making them billable and training and supporting and teaching them how to make what they do count, right, in the financial and data way. As far as public health, I can only say that this pushes us to further collaborate. So although we may not have the answers and, you know, funding answers to their current services, we will have to work closer together. And I'm sure that that's intent part of it, right, is to make sure that we all are doing our part in that system. I can't answer as far as public health goes.
Additionally, if someone called behavioral health that was experiencing postpartum depression, or a senior that was experiencing depression, they could still receive services and counseling. It just wouldn't be with that outreach.
Yeah, so, and we heard the feedback in the plan where there was a lot of feedback requesting increased referrals, right? Follow up on those referrals, not just one and done. Make sure you stay and keep in contact. And that is part of what having this new plan does. It assigns a peer support specialist and a case manager to almost every one of the Fidelity teams that will be doing that with every one of our populations that are mandated. They are that point of contact, whether it's picking them up, taking them there, helping them keep their appointments, linking them to those resources, making sure they get reminders, all of that stuff. We now have a higher accountability to them in that way.
I have another question. So what I'm seeing today is a structural change to the funding and to service. So I want to ask from a layman's perspective, how would that impact our Lake County? Is it more positive change or problematic change? Are you concerned?
I seem to have a lot to say. I'm sorry. Yeah, I think systematically it's going to be hard. We're taking a hit. You hear the 5% funding cut, you hear the programs closing. Like realistically, those services matter a great deal in many different, it's going to be extremely painful at first, but I believe in the end, we will all find where we're supposed to be and be better at what we do. You know that saying, like a jack of all trades, master to none, right? So like making us be better at what we do and being accountable for it gives opportunity for others to lift up and do what they do well as well. So in structure, you pull back, you get tighter, you lose funding, you don't have as much resources. But then again, the hope is that there's this a rise boat lift all tides, or a rising tide lifts all boats. That's it. Sorry, I'm getting there. But in theory, yes, for me, yeah, funding cuts, program reduction, like that, it's gonna hurt for a minute.
I mean, I would also recommend looking across all of the other counties in California. There's been numerous press releases regarding their adaptations because it is a seismic shift for every single county, not just Lake County, and that may help provide some valuable context.
Yeah, and I've always been saying 1 step backwards, 2 steps forwards. You know,
Change is scary in general. I mean, it's a big change.
Man, you don't even know.
I can say as a provider that's again, contracting with regional model and other counties, I've been surprised that Lake County's been ahead in a lot of areas when it comes to some of these situations and addressing it. I mean, the Sud Department has been doing amazing when it comes to things. They actually had a clear 100% audit recently, you know, I mean, which was amazing. That was really big. Yes, and shout out to Amber, if she's still there. I know she's quiet and humble, but she deserves a shout out. I don't think Lake County has ever done that before, and I've been fighting against Lake County Behavioral Health for lots and lots of years. Lots and lots of years. I mean, I now stand with a lot of things, and I actually said something the other day. Wow, I never thought I'd defend it, but God, this is wrong. They're doing it right, you know. And I truly believe that, and I'm not one that holds back on the way I feel or things that I see wrong. I stand up against it, and sometimes it's a battle, but I am seeing lots of positive changes. And one of the things that opened my eyes is when I was invited to a Community Behavioral Health Directors Association meeting. Thought it was a mistake, but I went. And went over the 73 initiatives that they were requiring. And my thought was, what, COVID, everybody decided to stay home and think up these plans and then make this happen? And we're not gonna give you any money to do it. I was blown away listening to some of these things. Like, I ended up, my meeting that I wanted to go to was full. And I went in one that had to deal with foster youth and the requirements and everything, and it was mind blowing as to what they expected from the behavioral health departments, but we're gonna take away your money to do it, to figure it out. And then again, working with Sonoma, that is a big county, to find out that none of their substance use outpatient providers were certified drug Medi-Cal, and they were just now working towards getting their Medi-Cal certifications so they could recoup, which meant all these years of services been paid for on the back of taxpayers' dollars instead of getting reimbursable and recouped. Where Lake County had had a substance use department for years, things that were surprising to me they were ahead of. And watching the fact that they are being heard down in the government in different areas. You know, Little Lake County is being heard in some areas where I didn't think they were. And I've witnessed that change through, I'll be honest, I used to call your old place the regime. You know, your old department, the old department before was the regime. It was really abusive and everything else. And new people have come up and lots of positive changes have been made. And there's lots of things that are just difficult. And I don't think any of us can comprehend how big it is, nor does the government. I always say I could never work for the government. They always tell me, you tell us we suck already, so you would never get hired. And that is true. I do say those things, but the reality is it's the only place I see, do this now. And we don't care how you figure it out, we're not gonna help. It's like, make it happen, and you're mandated to comply. And that's the state coming, that's the feds coming down on the state, and the state coming down on the counties.
Yeah.
And I don't understand how they expect the small rural communities to stay up with LA. I mean, dealing with the other new requirements now, because there's new requirements, because they have fires in LA. Now the state has to do incident response plans, because in LA, my response to them was, Northern California's been on fire for 10 years. How come you care now?
That is so true. Thank you so much.
Yeah, I sent that in. You know, I did. You know, it's like, you know, and so that's the reality. And so there's a lot, and also it's, you know, so there's just things, and they expect all the northern rural communities to stay up with LA. I don't know about you, but I don't want anything to do with what's going on in LA.
That's different needs than what we have here. All right, so, anyone else from the advisory board or
Yeah, I have a question. Hi, I'm Raven Shepherd with Lake County Behavioral Health. I'm a therapist here. I noticed that something about MotherWise, we're not going to be allocating grant funds to them. And I noticed it going to like maternal, child, and adolescent health and Canocti senior support. And are those like governmental organizations? And I ask that because, you know, in history, like we've had like there's the government, right? And then there's the community, and it's like and so many people had a hard time trusting government. And so like through the last like 10 years, community has began to trust government. And so are we going back to a medical model? Are we going back to like a governmental model, or are we like trying to collaborate with community? What does that look like moving forward by removing Motherwise?
Motherwise is not a government agency, nor is Canocti
Right.
Senior Supports.
Right. Yes. And so, and we're not gonna be working with them anymore. And so that's why I'm asking about
No, I wouldn't
the ones
characterize it
we
as that. I
are.
think we'll continue to collaborate and coordinate. However, it was a relatively small amount of funding we were able to provide through the MHSA that we are no longer able to provide. However, those organizations will continue to exist.
And so the maternal, child, and adolescent health, is that a government program?
That's from public health. So that's
Okay.
what I'm saying is there are
Okay.
resources and supports for that population. And our role is much narrower than that. So it's important for us to ensure appropriate collaboration and referrals to those existing programs within our community.
Yes, thank you. And Canocti Senior Support, is that a government program as well?
No.
Okay, thank you. That's what I was wondering. Thanks.
Great. I'm gonna go ahead and turn this over to public comment because we are running out of time quickly. Is there anyone that would like to make public comment? Please state your name and place of residence, and you have 3 minutes if you'd like to make comment. All right, last chance.
I will make a comment. And this is, I understand all of the changes. Oh, sorry, Carrie Manning. And I'm just. What? What's that?
I don't know, 3 minutes start now.
Okay, so I have 3 minutes. I want to comment that, our peer support centers provide valuable services. We're all well aware of that. I'm really hopeful at this point that in the future we can, recreate, we can expand out into every community within the county. And I just want to express concern that our unhoused population, our severely mentally ill folks, our Spanish speakers, our Native Americans have utilized our Pure Wellness Centers for many, many years. And I'm really hoping that there is a plan to provide those services for them. And that if it's not behavioral health that does it, that other, community-based organizations will step up and come up with a plan for people, because I know our centers have become a home for a lot of our community members. Mm-hmm. And, they are not going to have that safety. And safety based on the stages of development is that first stage of development that people have to have in order to start working on other pieces of their life. And it's very important that we have a consistent, safe environment for people to be at and to get linked with community services.
Here.
That's all I want to.
Thank you, Carrie.
I think I said that in a. Yeah, okay, thank you.
Carrie, this is Dina Smith. And I would like to know, what is your plan for this center here at Clear Lake Oaks? There are a lot of people that are homeless. It's going to be a hot summer. This is a cooling center. It's a heating center. It's where you eat. It's shelter. It's comfort. And I don't see any resolution that's been come up to it. You haven't brought anything. So what is your plan?
So we will continue to have a peer presence in Clear Lake Oaks, and we'll continue to facilitate the trailer shower that is operated by Adventist Health. as well as the food giveaways. I acknowledge that that has been a valuable place for the community. However, as we've been discussing this entire time, provision of food and basic necessities is no longer within our domain of responsibility. And so conversations will continue. However, I realize this is public comment and you asked a question, so I will stop.
There's nowhere to get out. There's no cooling centers to get out. We can't do some mixture, but get a mixture, put it up to a hose. Everybody has heat stroke. We can't do.
We can't understand you. Sorry.
He said, we're not gonna have a home, we're not gonna be able to eat something.
What he said.
Is there any way that the homeless will have a place to get out of this heat when it comes around? You guys have to go inside and have air conditioning and farm coolers and things in your air conditioning. In your car. We have nowhere to go to get out of the heat. Is there anybody who could find like a way to put like a hose up and put the mixers into gazebos maybe someplace in the park so people can cool down there maybe or something? We might cost $10, it might cost $20 or something. Could we pull that together? I don't know. I'm just being a little bit sarcastic about the idea, but I mean, we could think about some way. I just wonder what they're supposed to do because it gets really rough up there. We're gonna have a lot of people with heat stroke and all sorts of medical.
And animals.
Animals too as well that don't need to be there because of this situation, having nowhere to go cool down. You know? They're going to the bathroom, I suppose, if they don't want to, the dog to drink the toilet water, I suppose. And we have the filters everything. Excuse me, I have good on the
Thank you for your comment. I think that from what I'm seeing from being on the behavioral health board, for several years now, I don't think anyone at behavioral health is happy about closing the peer centers. I think that they're gonna try to figure it out. I mean, this is state mandated. I mean, I'm speaking out of turn, stop me, but it's state mandated and there's just no other option at this point.
And there are plans with different community organizations for what's called resiliency centers in each community. And so those are going to open when it's too hot or too cold for people to be safe.
Oh, can I say one thing? There is an SLE supporting Bright Futures. I'm not sure if everybody knows about them, but they've helped a lot of people gain housing. They actually have a house for men and women with pets. I think one, I don't know if they're full, but if you get a chance to talk to somebody about supporting Bright Futures, that's a really great. They do.
Are there any solutions in the work for a cooling center here for this summer? Because actually it was 91 degrees in Lakeport 2 days ago. So I'd say the kid's already
Red
here.
Cross and the COAB.
Pardon me?
That is through the Red Cross. And yes, there are plans to open a resiliency center in the Oaks.
Plans to.
That doesn't do us any good right now when it's already up in the 80s and almost 90s right now.
No, until May 29th, you guys have there, and then I'm sure somebody will open something after that.
How are you sure about that?
Thank you for your comments. We're gonna
How
go
are
in
you
and.
sure about that?
I'm sure about that because I've heard them talking about it in different meetings. I think they're just looking for a place.
I understand that this is a public meeting, and I've been here since before 10 o'clock, and I've seen that all of you up there got your chance to talk for more than an hour almost. And you leave us with 3 minutes to try to say everything that's on our mind. Okay. This is our livelihood. Your livelihood is when you get in your car to go home. So I think this should have been worked on long before because you have this information.
We've had many community meetings to discuss all this previously, and,
Yeah. And the
this
same
is
thing happened.
this is the hearing for the integrated plan. And unfortunately, there's state mandates that behavioral health is having to follow. I mean, it's nothing against, I mean, in my job, I work with very, it's been a wonderful resource. So I understand your guys' loss, but I think that behavioral health is going to address this as it comes. And I mean, they're already talking about how to fix this. Their hands are tied at this point.
Is the public comment still open?
She's listening.
No, I mean, because they.
If you'd like to say anything, but you can still,
Public comment is still open. She
you can
hasn't
talk.
closed
Yeah,
it.
haven't closed it yet. So, but each person has 3 minutes to talk.
What else is on your mind?
How disappointed we are. We are. Because we trust you. We trust that.
Oh, we did.
We did. We're disappointed in everything right now because this center helps a lot of people. Of all centers, there's no transportation here. And I'm not saying, gimme, gimme, gimme. That's not what anybody here is saying. They're saying this is a necessity in this town. It can't go, oh, we're just gonna play it by ear until this all happens.
I think what everyone is saying is that we're working on it. Hold up. We're working on it. And I think if you interviewed each one of us privately, we would all be crying because the center is closing. We would just be crying.
We are.
Just like you.
Not just
No, not like that. Not like that. We are being harmed by the decision of closing the center.
It's not.
Yes, you are, yeah, but these will be replaced. You're gonna have something we just don't know yet.
Well, that's the problem.
That's why we're here. You just don't know yet. We'll think about this day and night.
I think in this is a good time, like, to write your congressman, your government, because they're the ones that brought this down.
So my name is April Gambra. I am with the county. And what I would like to offer is, may I come down there and speak with each of you to kind of hear this so that I can figure something out? I can't make any promises. The center's still gonna do what it's doing, but you're right. This is causing harm and it does need to be heard and addressed, and I'm willing to do that.
April?
Yes.
That would be really nice if you came down to campus individually.
Okay.
You have more resources. You are our resources. You understand that? You're our resource.
I do. I've been on the streets in this county and I know how hot it gets. And I've been incarcerated, I've been without food, and I do understand. And I would love to sit down and speak with you guys if you'll accept me.
That would be so great.
Okay, thank you.
Dina, this is Melanie. Hi.
Melanie.
Hi. I just want to say that, we all do care about you guys, so hang in there, okay? And maybe write some ideas down, okay? Maybe talk to the other peers that are there and get some ideas. So when April comes, you guys can work it out. Good to see you.
You too.
I just wanted to make another comment about like what I was talking about earlier about asking about government programs, things like that, and the community, the report that that we've built and people have built with the community, and me being a community member as well. I definitely understand the gap in services that this is going to create, because I've seen the changes that the peer support centers have made for so many people, like people that never thought they would have a chance at life, actually had a chance when these peer support centers opened. And so it is very heartbreaking that they're closing and things like that. And I'm hoping, and I'm just hoping that we're not going back to a governmental medical model that looks from the perception of psychological factors, because this was like a humanistic type of environment. The peer support centers were more people first, not psychologically, like, it wasn't like that. And so I'm hoping that we can keep on working towards, shared goals is what I'm hoping. Thank you.
This is for the board. Is there any additional business? Or standing? All right, so we're gonna go ahead and adjourn this meeting at 12:10. Thank you all for taking your time out to attend and have the conversation. I do want to give a shout out to the peer centers because you guys have made a big difference, and I think that we need to recognize.
Yeah, we want to make a shout out to the Peer Center too, because everybody who works here is like, they've really helped a lot of people here. And I speak for everybody.
I'm right.
Can change this whole.
Thank you, Stacy.
April, you work for, I don't know.
She already bailed. Yep, they bailed.
They bailed.
Yeah, they asked them to break off.
Yeah.
It's over. I shut it down, Ken.